Welcome, everybody. My name is Lauren Tobias. I am taking over just for the week, filling in for Sri Thapa to introduce our speaker this afternoon. So I want to welcome everybody to Yale Sleep Seminar. I have a few quick announcements just before I introduce our speaker for today. As most of you know, in order to receive CME credit for attendance today, you can see the chat room for instructions. You can text the unique ID for this conference anytime until 3:15 p.m. And if you're not already registered with Yale CME, you will need to do that first. If you have any questions or comments during the presentation, I encourage you to make use of the chat room throughout the hour. We're also going to have some time at the end for folks to unmute themselves and ask questions aloud. And finally, please feel free to share the announcements for our weekly lecture series with anyone who you think may be interested. And you can contact Debbie Lovejoy to be added to the email list. So now I am delighted to introduce Dr. Pallavi Patwari as our speaker for the sleep seminar. She is Division Chief for Pediatric Sleep Medicine in the Department of Pediatrics and an associate professor at Rush University Medical Center in Chicago. She completed medical school at the University of Illinois in Chicago. She did pediatric residency, including a position as a chief resident at Advocate Lutheran General Hospital, and fellowships in pediatric critical care and sleep medicine at Northwestern. Dr. Patwari has expertise in pediatric hypoventilation disorders, and she's interested in the impact of critical illness on sleep in pediatrics. She's very involved in sleep education for trainees. She's run the pediatric sleep medicine rotation for residents and sleep fellows at Rush, as well as hosting sleep fellows from the University of Chicago. She has spoken locally and nationally on issues ranging from pediatric sleep disordered breathing to hypoventilation disorders to sleep as it relates to pediatric critical care. And she currently serves as Vice Chair of Faculty Affairs in the Department of Pediatrics at Rush. So please join me in giving Dr. Patwari a warm welcome for her talk today, which is entitled Sleep Problems for Teens, More Than Bad Habits.
Hi, thank you so much for that introduction. It's part of it was like, are you talking about me or somebody else? Let's see here if I can get the PowerPoint up. I would like this to be interactive. I can't have the chat and the presentation at the same time. So I would say feel free to unmute yourself, or if somebody doesn't mind reading the chat, I don't mind interruptions. I think it just makes this lecture go a little bit faster. So anyway, approach to sleep problems in adolescence more than bad habits, because everyone thinks teens are just lazy, but they're not. Maybe they are, but we'll get into that. All right. CME disclosure here and the code. I have nothing to disclose. And then you have your CME code there, 40538, it looks like. I do have to disclose that I am a mother of teenagers. So my daughter, who is an artist, did this picture of my 3 kids, all teenagers. And I love this because it shows how moody or angsty they can be at times, in addition to being lovely. So I'm going to talk about identifying normal sleep duration and contributors to inadequate sleep for teens compared to other age groups, describe the effects of poor sleep in teenagers. I'm going to briefly talk about the differential diagnosis for daytime sleepiness in teenagers, just for completeness. And then hopefully I'll have time to go over their circadian sleep-wake rhythm disorder delayed sleep phase type, because this is pretty common in kids and teenagers. So Adolescence. So it's a period of transition. When we think about adolescence, it's classically teenagers. So the teens are 13 to 19 years of age, but truly biologically, there's changes that are happening even earlier. So puberty can start as early as 8 or 9 years for kids. And so there's a lot of variability, not just in biology, but also in social and environmental transition. So this is really important to keep in mind when we're thinking about adolescence. And I'm going to use the terms adolescence and teens a little bit interchangeably here. So how much sleep should they be getting for teenagers? So the National Sleep Foundation says for 14 to 17 years of age, they should be getting 8 to 10 hours of sleep. That is generally recommended. The range can be 7 to 11. And so this was published in 2015, and they looked at many articles. I want to say like 60 articles to kind of come up with these numbers here. And so this is I like this, and I'm going to pull up this study a couple times throughout the lecture here, but this is the 2006 Sleep in America poll from the National Sleep Foundation. And so they looked at sleep time on school nights for teenagers based on grade level. Okay. So they interviewed 1,600 kids. So this is all self-reported, but parents and by kids in 2005. And just to give you a little context, I think the iPhone came out in 2007. So this is pre-iPhone. So we have our major life markers, iPhone, COVID, and who knows, other things here. So anyway, 45% get insufficient sleep. So that's less than 8 hours. And this number increases by grade level. And I apologize, the graph here, the table here, the font is super tiny, but basically for the 6th to 8th graders, 21% have insufficient sleep. But once you get up to these 12th graders here, 75%. So it really is pretty dramatic here. Okay. And then, of course, and if you look at the other way, how many are getting optimal sleep? So we're seeing the inverse here, 6th to 8th graders, 35%, so the highest. And then 12th graders, we have barely anyone getting this quote optimal amount of sleep, so 9 or more hours on school nights. And then even the teens recognize themselves if they feel that they get enough sleep to feel their best. So of all of them, 56% feel they sleep less than they need. And this changes by grade level. Again, 9th graders, about 50% feel like they get adequate sleep, whereas inadequate sleep, I should say, whereas 12th grade it jumps up to 72%. Okay. And then looking at this is data from 2015, so a little bit more recent, but this is the duration by state. So the grayed out areas with the stripes, there's not data, but you can see in a lot of these, the numbers are 60 to 80%. Okay, so definitely there's some regional effects as well, which is interesting, which I won't get into, but something to think about. So this I like. So this paper also is a little bit more recent. I like the Great Sleep Recession, because that really is really what this is. So they looked at the percentages of teens who reported the greater than or equal to 7 hours of sleep, and then those who reported getting adequate sleep per night. And so for since they used orange for all the lines, I tried to highlight here for 1991 to 1995, we have these numbers here. And then these numbers are changing over time too. So even over time, we're seeing this drop in teenagers who feel like who report, I should say, getting greater than 10 hours of sleep. And then a drop in the amount of teenagers who get adequate sleep per night. And this changes by age. So again, here's 14 to 17. And you can see these numbers are just like plummeting down until 18 years. And I'm thinking here, this little bump at 19 is when they get to college. They can choose their schedules. They can have afternoon and evening classes. So, but this is pretty dramatic and interesting. And really, this is data that Dr. Mayor Carskadden has shown for decades, really. Similar stuff that older teens sleep later. And here it's showing sleep less, but I'll get to that part. Okay. And then I don't know if there's some, it looks like a note for the chat. So what do we know by objective measures? So actigraphy. So actigraphy, I'm not sure if, does everyone know what that is or some? So actigraphy is like a little Fitbit, you wear it on the wrist. It measures movement, it can measure light. And so you can use that to get a sense of sleep time. So this is a more objective measure than the surveys, the self-reports, parent reports of sleep time. So what does actigraphy show? And this is a nice meta-analysis, and it shows that the average sleep duration decreases with age. And it's, again, same thing as we're seeing with the surveys, it's lowest for the older teens. And sleep duration for the older teens is less than 8 hours. So the 15 to 18, and then their average is 7.4 hours. The differences here, they use the 9 to 11-year-olds as the reference when they were comparing. And so compared to the reference, this is, almost 2 hours, 1.5, I guess, hours less sleep than the 9 to 11-year-olds. This is a little bit more complicated. So with their meta-analysis, they plotted by age and the strength of the study. So it was a bigger bubble if it was a stronger study. And again, with this data, they showed, again, the teenagers here, we have decreasing amount of sleep as their age goes up. Okay. And 8 hours is there. So they're really definitely, as they get older, crossing that line, getting less than 8 hours. So so the recommended amount of time is 8 to 10 hours, which is worse for older teens. So why are they not getting enough sleep? Can people unmute? What do you guys think? Or not unmute, I guess. Anyone? Okay. All right. I'll just keep going.
Homework.
I guess social media.
Social, yeah.
Social media.
Sorry.
And I think as well, the start time of schools is like too early. And it's out of alignment with their natural circadian rhythm.
Yeah, excellent. There, you stole my talk already. There's but yeah, no, excellent. Yeah, so very good. And I can't read the chat, I apologize, but I see some notes there. But really, there's multiple influences on sleep, right? And all these influences are really integrated. Okay, so one thing that I like, this is Stephanie Crowley, who's here at Rush. She does research with adolescent sleep, and her mentor is Mary Carskadden. And so they come with, I like this, the perfect storm. So another term to kind of say, we really have all these things going on. And so you have the sleep duration here that decreases as kids get older. And so they have bioregulatory, psychosocial, societal. So there's a lot of ways to kind of look at this. So I'm going to simplify it into biologic, neurocognitive, environmental, and social, even though really it's a little bit more complicated than this and more overlapping. So environmental, what do you guys think for environmental factors? I know you said school start times.
I saw other people had put in the chat screen time.
Screen time, great. So home stability. So I'm not going to talk a lot about it, but there's definitely papers out there that show teens' relationship with their parents, stability in the home, that makes a really big difference in terms of effects on their sleep. So that, I think, hopefully makes sense. School start time, which I'll talk about, which is great. And then drugs such as caffeine. So sometimes kids are getting these Starbucks and stuff, don't even realize that they have caffeine in them. And then electronics. So awesome. Okay. So hopefully I'm not telling you guys stuff you already know here. So here, again, going back to the Sleep in America poll back from 2006. But what this shows is that you have school start time, which stays the same from sixth grade. And if we're looking at high school, 9th grade to 12th grade, it stays generally the same around 8 a.m. Okay. Their wake up time is generally 6:30. So the red line is what time they're leaving the house. But in order to get to school at 8, they're waking up at 6:30. But if you look at their bedtime, you see that it's increasing for every year of high school. So we have 9th grade at 10:15, and it's increasing by 15 to 20 minutes every year. So up to 11 p.m. So when you have this, if you obviously do the math, later bedtime, same wake up time, you're getting less sleep. So, so that's definitely one thing. So early school start times are not in line with biologically different later bedtimes. So this is exactly what I think Laura said here. So gold star for you. Caffeine, 2 or more cups a day are associated with insufficient sleep and daytime sleepiness. So, right. So kids, they don't really, it's kind of a social thing and they don't really realize. So I always ask, how much caffeine are you taking? How much soda or Starbucks, things like that. And then electronics. So this I thought was really interesting. There's some newer stuff about this. So I'm going to go over this. So this is a review paper, and they looked at it in a little bit of an unusual way, but they looked at devices and outcomes and impacts. And so there's a lot of variability. So they felt that they couldn't compare them directly. So they said, how many studies, what percentage of the studies found an association of adverse outcomes? So between all of these devices, 76 to 94% of the studies found some adverse outcome or impact on these sleep parameters. And just again, asking the audience, what do you guys think about which device would be the most impactful versus the least in terms of the number of studies, I guess. Again, it's a little bit funny how the data is presented. Okay, I'll just tell you here. So 76% for television, 94% for computer use, video game use. So really computer use is the big thing. Mobile devices have 86. So I'm going to dig into this with another study. Let's see, limitations, which I already talked about. So it's hard to translate this to, statistical significance is not necessarily clinically significant. You can't determine causality, right? So these are all just association. So do kids who don't sleep enough, do they tend to play more video games? Or is it the video games that's causing it? You can't really tease that out from these type of studies. Also, a lot of these are based on self-report, so kids reporting it or the parents report. Okay, so this study I often talk about to families. So you have a cohort of 700 kids ages 12 to 18. They have an average total sleep time of 7.7 hours. Okay, so about 46% reported having greater than or equal to 8 hours. So that's pretty typical from what we've seen, from the other data, right? This is not surprising. Average bedtime 10 p.m. Lights out average 10:36, and the sleep onset average was 30 minutes. But they clarify that it's more than 30 minutes for about 30% of the kids. So a little bit wider range. So they looked at how much time did they spend on these devices before getting into bed and while they were in bed. So the phone here, not surprising, is the highest, right? And look at this, it jumps up. They get into the bed and then they grab their phone and they spend 45 minutes on their phone. So that's really, I think, important to know. Laptops is next. And you can see once they're in bed, less use. And then obviously desktop is not even, you can't pull your desktop into bed, so that's low. And then people are watching TV before bed, and then in bed, it's really a short period of time before they fall asleep. So besides that, what applications, what are they doing on their computer before bed, right? So there's Snapchat, YouTube, texting, Instagram, Netflix. And so they looked at all of these things. And Facebook here. And they showed, here's the summary here. And this is really interesting to me, Snapchat and YouTube, right? These are the two highest here. The one highest really is the iPhone. And I'm marking 30 minutes here, 15 minutes. So you gave a sense of 15 minutes. So to compare. So what they found was if using the laptop for 30 minutes before getting into bed, delayed the lights out time by 9 minutes. The phone use was 30 minutes was associated with later bedtime of 9 minutes also. Watching TV was associated with an earlier lights out by 9 minutes. So all those things where they're like, don't watch TV before you get into bed, don't watch TV, I stopped pushing that. As long as there's an end time to the TV, it may not impact sleep onset time at least based on this study. Gaming and YouTube. So these have a greater impact. So 30 minutes on these devices, you have a later lights out time by 16 minutes for gaming, 13 minutes for YouTube, and a shorter total sleep time by 14 minutes and 11 minutes. So if I have a kid who's using computers or phone or whatever, if I'm going to make one recommendation, it's going to be like, put your phone away and don't be on YouTube, right? Don't be on your video games and don't be on YouTube. So I guess that's 3, right? Not 1. But these are, I think, make sense as well, because gaming in particular, you're engaged with it, you're interactive. YouTube, what's interesting is it just keeps going, right? And so it's very easy to be engaged with that and not have an endpoint to it. And then they looked at in bed. Okay, so if we go back, time spent in bed with these devices and with different things here, they found that laptops, phones, tablets was associated with the later lights out by 7 to 9 minutes. YouTube, if they're doing YouTube in bed, again, lights out delayed by 13 minutes and shorter total sleep time by 11 minutes. And then this I thought was interesting is Netflix was associated with increased daytime sleepiness, but no objective changes. So when I gave this lecture to our group, people were hypothesizing that people were binge watching and then having weird dreams about Squid Games or whatever. So the questions about this, I feel like this was pretty interesting and relevant.
I couldn't help but notice that TikTok was not part of the study. And I imagine they prepared this maybe in 2021, and then it says it was published in 2022. But now, I mean, I wouldn't say is it number 1 or number 2 or number 3, but I imagine it's one of the top 3 in terms of the total amount of time spent.
Yeah. And this was probably, again, with technology, like this is evolving and changing, right? So very quickly. So, but I think this is probably one of the most robust papers looking at things. I really liked how they presented the material and looked at it. I thought it was really thoughtful. And but yeah, a lot of things they may be looking at them, but again, you can't compare as easily. But TikTok, yeah. I usually tell people not to do TikTok just for safety reasons, because they always have like weird challenges that are physically dangerous. Okay, so going on, so social neurocognitive. So neurocognitive, so their brain is still developing for teenagers. So problem solving, abstract reasoning. So this is still being developed, right? They're still learning these skills, and it's evolving even until they're like 22, 24 years of age, right? social, growing independence, increasing expectations. And so these, I kind of put these together because I feel like there's a lot of interaction between the two in terms of how much freedom do they get versus how much they can handle safely. Okay. So, changes in expectations and habits. So a lot of catastrophic thinking. So, academic pressure. School classes are harder. They're really worried that, you know, one thing is going to make a huge difference in the rest of their life. Increasing independence from parents. So bedtimes become less regulated. So for the teenagers, parents are just saying, go to bed, and they can be quiet in their room, but may not necessarily be going to sleep. And which I actually see a lot in my clinic, where I'm asking the kids, so what time do you go to sleep? What time do you put your phone down? And they're like, oh, maybe 1 or 2 in the morning. And the parents are like, what? So again, this kind of goes back to parent-child relationship too. And then this, again, copying from other reviews, like how they've been looking at it. So home influences, social and cultural, and then individual factors. So we kind of talked about these a little bit here. And biologic, we mentioned puberty, changes in endogenous melatonin, resistance to sleep pressure. So I'm going to talk a little bit more about these things a little bit later as I talk about circadian rhythms. I do want to digress and talk about how to talk to teens about changing behavior. And this is actually not just teens, but there's something called motivational interviewing. And have you guys know what motivational interviewing is? If you're a pediatrician, then you definitely do. So you have to dig into where are they at in terms of making changes? Are they motivated, or are their parents motivated? Because if it's just the parents, this is like changes are not gonna happen. You have to get the teenager to be engaged and to feel heard, and to get a sense of how ready they are to make changes. So there's really like a whole, I wish I could spend more time on this, but it's really interesting. And I think it's been really effective when I tried to use some of these strategies. When I've given this lecture before, I've had one of the fellows say, oh, but then you're manipulating them. And it's not manipulation. This is ways to help with communication. So it's really, it's not manipulation. And then, so parent support and engagement. So again, talking about relationships, parents have to be reminded that sometimes these teens do need a little bit more support. They need a little bit more attention. They're not adults, they're kids. And so that's really important. I pulled this mindfulness paper on mindfulness activities. I'm particularly interested in this. So in this study looked at mindfulness-based activities in the school setting. So it improved stress, but it did not have an effect on depression and anxiety. And the overall effects for these mindfulness activities were significant compared to doing nothing. But compared to they called active controls. So if you're comparing it to anything else, yoga, substance use, any kind of health awareness, they're pretty similar. And so there's so many books out there. There's some of these, I had to put Craig Conneper's book on here. I have it. I apologize. I haven't read it, so I don't know if it's good for teens, but the ones I recommend for younger kids, not for teens, is What to Do When You Dread Your Bed. What I've done is, this is a book that I created out of years of creating handouts. And it's a Spanish version and English, but basically it's just telling them to practice 10 days, 10 minutes, do deep breathing, do muscle relaxation or yoga or guided imagery. And then there's coloring pages so they can tear them out put a feeling word. It seems kind of silly, but I've done this with my teenagers. I've given it to other families. It's a way that is safe for the teen to interact with a parent, so without forcing conversation. And so it's meant to be boring. It's not supposed to be super exciting. And so anyway, but it's basically a handout. And if you guys want to know more about that, just let me know. All of these are available on Amazon, and this book is not meant for profit. I'm losing a lot of money on it. So please don't think I'm trying to sell you something here. So practice, practice, practice. So I'm going to age myself here. Danger, Will Robinson. So what happens when teens don't get enough trouble? So this is the Will Robinson, the robot back then. This is the newer one in the newer version, the remake. And so a lot of consequences with sleep disturbances, with substance use, and other things. So lower academic performance, effect on brain development, risk-taking behaviors, mood and emotional regulation, in terms of looking at the overlap, because it's a spectrum, right? So in terms of adult pathology, we see some of these obesity, adiposity, cardiovascular effects. And then I'm going to spend time talking about motor vehicle accidents, because I think this is really very tangible, and there's a lot of shifts happening to pay attention to teen sleep based on that. Insufficient. So this cartoon is taken from Hyperbole and a Half, and this is a woman who is very open about struggles with depression. I just think her cartoons are hilarious. So, getting all excited, and then they're saying, stop yelling at us, which is like my house, where I'm like, yay, and then they flip their emotions very quickly. So check her out if you're interested in depression comedy, I guess. All right, consequences of insufficient sleep. Again, chronic sleep loss and mood behavior. So lower achievement in school, and they don't enjoy school as much. So again, when I see teens in clinic, I'm always asking, how are your grades? How are your grades now? How are they compared to last year? So this is a really nice marker of, how impactful are the sleep problems for them. There's increased risk of alcohol and drug use, as we talked about, poor judgment effect on decision-making skills and mood regulation. And then this, I don't know if I put it, I don't think I put the slide here, but sleep less than 8 hours is associated with almost a 3-fold increased risk of suicide attempts, and bedtimes of midnight or later were 20% more likely to have suicidal ideation. So there's another paper, which I don't think I included, more recent one looking at the review, but there's definitely a very high prevalence of sleep complaints with suicidal ideation and suicide attempts. It's like 30% or something extremely, extremely high. So this is also really important. Talking about sleep is for every teen that I'm seeing, I give them the modified PHQ for teens. So it goes over suicide risk. Insufficient sleep and obesity, again, similar to findings in adults, some biochemical stuff, which I won't get into, because again, this could also be a whole lecture in itself. Insufficient sleep in teens, so motor vehicle accidents. So sleepiness while driving. 65% of 11th and 12th graders admit to being sleepy when they drive. And 50% say it's a regular behavior. So that's kind of scary, right? So we're worried about drunk drivers. If you're sleepy, you're also impaired. Kentucky, they changed the school start time, and they saw a 16% decrease in teen motor vehicle crashes. This is compared to the 7.8% for the rest of the state. In Virginia, so they moved the school start time by 50 minutes from 7:20 a.m. to 8:10, and it was associated with decrease in accidents and distracted related crashes. So this was 2.9 versus 31 per 1,000 and 6 versus 7 per 1,000 respectively. So this is the distracted driving. And there's multiple papers. And this is a different state. So Minnesota, they showed that so baseline is the 9th grade, follow-up is 10th grade and 11th grade, and they delayed school start time was, they found a consistent increase in sleep time. So it's not a short effect. So this really can be sustainable, this increasing the sleep time, right? It's not that you make it later and then they just sleep later. They are actually getting more sleep. And then Cochrane review with later school times, potential association with psychosocial outcomes, mixed results with academic outcomes, decreased depressive symptoms, and significant positive relationship between later school start time and the amount of sleep. So 6 studies, they said, from that Cochrane review. Again, this is this is just the summary of what I just said. So I guess there's even more coming out. When I try to look up things, there's even more that's really supporting this, that it's not just helping them do better in school, but this is a public health safety issue. Again, questions? No. So summary, you have physical health and safety issues, mental health and behavior issues, and academics and school performance. So chronic sleep loss, definitely something we need to pay attention to. I'm going to very briefly go over the differential diagnosis because I want to have a little time to go over circadian stuff. So teens may come in and they say, I can't fall asleep at night. I can't concentrate in school. So it could be they're not getting enough sleep. Maybe they just have some bad habits, maybe just teaching them a little bit about having good habits. By the time they get to a sleep clinic, though, most of the time they've read enough to know what good habits are, and they're all trying really hard. They're like buying these meditation apps and they're doing lavender aromatherapy or whatever, things that are geared to help them feel relaxed, but doesn't help them with sleep. Insomnia can be exacerbated by anxiety. So you always have to screen for anxiety and depression, mood disorders. And also, are they actually sleeping or are they just staying in bed? So that's another thing as an avoidance behavior, which is, reasonable if the bed is a safe place. They may not leave their room. Other disruptions. So just like all other ages, we have to look at sleep disorder breathing. Are they snoring or not? Are they moving excessively overnight? Could they have narcolepsy or idiopathic hypersomnia? And circadian sleep-wake disorder. So now this is, I'm going to shift here and hopefully I can get this through this in like 5 or 10 minutes so we have time. So there's a criteria for circadian wake rhythm disorder. So this is just a misalignment of the endogenous rhythm compared to the actual schedule. And you have, and then you have daytime symptoms, and then it really causes impairment, right? So you have your typical schedule, but your endogenous schedule wants to be later than what it should be. Okay. You have to have symptoms for at least 3 months. And you can use a sleep log and actigraphy to show this. And then, so I don't know if prevalence is 7 to 16% in adolescent and young adults. And so just to digress a little bit here. So looking at actigraphy data, you have to take into consideration that kids in general may move more than adults, because there's a lot of use of these commercial devices to say, okay, you've gotten, I have families coming in saying, I'm worried my kid is not getting enough REM sleep. And I'm like, what do you mean? Like, so these devices say they're doing these things, but really it's looking at just movement. And so you can't really know how much deep sleep versus REM sleep, that kind of thing. And so it's really hard to interpret that data. So a lot of times I'll say, don't even look at that. Please fill out a sleep log, or we'll do an actigraphy where it's somewhat standardized. But now that the ActiWatch is not being made anymore, or newer devices, this has become a little bit more of a challenge. In looking at the data a few years ago now, comparing sleep log data versus actigraphy, the sleep log can be actually pretty accurate. And a lot of times in practice, what I do is I have parents fill out one worksheet, and I have the kids fill out another one. And so it kind of puts the onus on both of them to pay attention to what the sleep schedule is. And it also gives me information about how motivated are they to address this issue or not. Because if they can't fill it out, then I know I got to go really slow with making recommendations. So developmental changes. So development of an evenness chronotype. So there's a buildup of a homeostatic sleep pressure, is slower in more mature adolescents as compared to early puberty. The circadian period, so the day length becomes longer, and there's alteration to the phase effects. So chronotypes, so night owls versus morning larks, as kids get higher grade level, again, going back to the 2006 poll in America, you see there's a shift of becoming more of this night owl chronotype. Now, talking about what I mentioned earlier and applying it to the two-process model. So the buildup for here, this homeostatic pressure. So this is the sleepiness. The higher this is, the sleepy you are. This is clock time on the bottom, if for people who haven't seen these graphs before. So 7 a.m., this is almost, this 11 p.m. and then 7 a.m. again. Okay, and so you have homeostatic pressure. Basically, once you wake up at 7, your pressure just slowly increases. Once you go to sleep, it drops pretty quickly, right? So for teens, what happens is this sleep pressure is not as robust. It's easier for them to stay up later than, say, for me, definitely, but their parents and anyone older. So this is really important to keep that in mind. So this is one part of it. And then there's a change in the circadian period, the change in response to phase effects. And then there's delay in the dim light melatonin onset. So both of these combined really are the perfect recipe for shifting that sleep schedule later. And so here, just again, for people, this is a study looking at 2 individuals, dim light melatonin onset. So melatonin is naturally released. And then in the evening time, what we look at is, when is there a big jump in this level? And that's the dim light melatonin onset. And then we have levels that peak during the sleep period. So this person here has a delayed sleep phase, because their increase, this peak, this dim light melatonin onset is happening much later. This is happening for this person, like 2:30 in the morning, as opposed to, 11 p.m. For a more typical sleep schedule. Oh, sorry, this is super busy. If you want to read it, I think it's really nice, but this is the phase response curve. I'm not going to spend a lot of time on this. Basically, it means that if you give melatonin at a certain time, you can have a bigger impact. And I hope I don't have a simplified version. And then if you give light exposure at a certain time, you can have an impact in delaying the sleep phase or advancing the sleep phase. And I can come back to this and talk about it a little bit more if you want, but I apologize, it's super busy. It's a lot of information. Based on that, the phase response curve. So I'm going to kind of translate that to what this means for us. So melatonin onset is about 2 to 3 hours prior to sleep onset, the dim light melatonin. You see this jump, right? So in a normal sleep phase, you have this peak around 8 p.m. It's jumping up. And so when families are saying, I give the melatonin, it doesn't do anything. So they're giving it at like, you know, usually 9 or 10 p.m. So in this area here, you're not going to see an effect, right? If they have delayed sleep phase, you know, I'll talk about treatment for that with giving melatonin, but again, timing is different. So their dim light melatonin onset is much later. Okay. Core body temperature is another a feature of how we can tell about when's the right time to give melatonin or light exposure, but there's no way to clinically track that. It's not. So this is more kind of just to give you an idea of where these numbers come from. So this little triangle here is the temperature nadir. So that's important for when things shift in terms of when the effects of light and melatonin. Okay. So phase response depends on timing. Okay. So melatonin is generally ineffective if you're getting it after the dim light melatonin onset. So that's why a lot of parents, the pediatrician is saying, give it an hour before bedtime, and parents are like, it does nothing. So we went up on the dose, and then we went up on the dose, and then they're giving their kid like 20 milligrams, which is huge, which is another issue. So to cause the maximum phase advance, to really pull that sleep schedule earlier, you want to give it about 5 hours prior to sleep onset. Okay. If we really want to pull this earlier. Okay. So usually the time to give it is much earlier than you would expect. If we end up doing the math for these kids with delayed sleep phase for 5 hours, it really ends up being about 1 hour before they're where they want their bedtime to be. So it does work out. Light exposure. So light exposure before the low temperature can cause phase delay. The reason I bring this up is because sometimes kids are waking up and getting ready for school before this temperature nadir, right? So they're getting up and the parents are like opening the curtains, showing them sunlight. So this may actually not be that helpful for these kids. You may have to have them kind of be in a dark room for like a week or so, or wear sunglasses as they're getting ready in the morning, those yellow sunglasses or something. In theory, it's really hard to implement this. And also, again, we don't know exactly when their temperature nadir is, right? If you give light after this time, so if they're waking up based on their phase, if they're waking up here, right, this is the sleep period. If you give light like an hour or so before they wake up, their natural wake up time, that can help advance the sleep phase. So that can help pull the sleep schedule earlier. Okay. All right. So that's just a summary. Oh, and I just want to mention, again, Stephanie Crowley here at Rush talked about giving extended bright light exposure on the weekends. So it's hard for kids to, they're like rushing in the morning. You can't like sit for 30 minutes or 10 minutes to get that light exposure. So what about doing it for a longer period of time on the weekends? And so she's shown that short-term weekend light exposure can actually be effective. So I've been actually recommending this more often. The perfect storm. So I went through that circadian stuff really quickly. Perfect storm. So this is, again, Mary Carskadden. You can't talk about adolescent sleep without bringing up her work. Sleep timing, biologic, social, all these factors play a role in terms of getting this sleep period from being this long to having a much shorter sleep period. And then just general recommendations. So I talked really fast. Any questions?
Thank you so much, Dr. Patwari. That was great. I see a hand raised from Dr. Clara Yagi.
Thank you for that talk. That was very interesting. As you were going through some of the data showing the higher risk for suicide among children, adolescents, related to insufficient sleep. But maybe there is this interest, and I'm curious as whether this is permeated more into the pediatric literature. But in the adult side, Michael Perlis from UPenn and Michael Grandner have been putting forth this hypothesis and starting to demonstrate that this hypothesis called the mind after midnight, that it may not be necessarily the insufficient sleep itself, but or the delays or an individual sleep disorder, but just the fact that people are awake in the middle of the night when they're supposed to be sleeping, from like that 2 to 4 hour, when our executive function doesn't work and we're more impulsive. And they very elegantly, I think, showed significantly higher suicide rates among adults in the middle of the night. And I'm just curious as to whether that's something that is in when it's investigating on the pediatric side.
Yeah, that's interesting. I'm not, my background's not psychiatry, so I don't know all the literature on this. But that's actually curious, because this is talking about timing, right? So like that period in the middle of the night when nobody else is around, when you don't have other potentially social support, like where parents are not available. I mean, it would make sense that we may see that in teens, but I am not aware of any data that shows that.
In teens.
Yeah.
I think it was I think they're more indicating that the brain is just different at that time of day in terms of its cognitive functioning. And I think we've all experienced it, waking up in the middle of the night and we're not at our most rational in that time of night. And so it's just sort of interesting that I think it's just now being explored on the adult side. I was just curious if that's something that's being looked at on the pediatric side.
No, and I can't imagine that those studies would be easy to do, because I don't know if anybody would either wake up kids in the middle of the night to do some neurocognitive testing, or allow for
you'd have to bring them into a lab to sort of demonstrate something.
So in terms of timing, that's a really interesting question. I'm not aware of any data looking at that. I don't know if the other pediatric sleep people, in the group can comment on it, but I can say definitely that there's the timing of sleep in terms of the delayed sleep phase, like if they're supposed to be, so if they're supposed to be functional, and the way, I guess, translating this to kids, if they're supposed to be functional during a period where their body wants to be sleeping, which is kind of like, going to school at 7 in the morning when you really want to wake up at noon, it's kind of like trying to be functional at like 2 or 3 in the morning.
That's interesting.
Yeah, so they're poor academic performance.
It's obviously confounded, I think, by homeostatic sleep drive and sleep pressure, but I think you could adjust for that. It's just sort of an interesting hypothesis. I think that, and you make a good point that you could explore this at other times of day for kids who are delayed, and certainly circadian rhythmicity plays a role in it. Thank you.
Yeah, no, very great question. Yeah. Anyone else? I went through the circadian stuff really quickly, so I hope it wasn't a blur there.
I think it's great that you sort of reiterated the message about the melatonin, just because I feel like every one of my kids' friends is taking melatonin gummies at bedtime, to the point that my own children have said, I need gummies to fall asleep. And
yes. And
I feel like there's also you're working against a message here. I mean, you mentioned the point about really not decreasing sleep latency effectively. I'm just curious, how do you actually counsel patients about the use of those if you don't think they have delayed sleep phase, but it's more just insomnia, initiation insomnia? What do you tell parents and teens?
Yeah. No, that's such a great question. So melatonin, and I dig into the literature a little bit of this recently. So the amount of melatonin overdoses has skyrocketed, increased by like 400%. The amount of commercially available melatonin for children has increased. They're packaged as like candy, like gummies or yummy tasting little tablets. And so there's two things that really bother me. One is that it's not tightly regulated. So the melatonin dose that parents think they're giving to their kids is somewhat unknown, because it can be widely variable. It can be contaminated, but with serotonin, because it's a byproduct of it. And it's interesting to me how terrified parents are of giving their kids caffeine, more so than they are of giving their kids melatonin. Because I feel like caffeine is a little bit safer, I mean, honestly. But the melatonin, also the idea of I need to take something external to be able to fall asleep. I think teaching kids that is also problematic. And people don't understand the timing is probably more important than the actual dose. And the dose they give tends to be really high by the time they get to me, especially for the teenagers. They're taking 20, 30 milligrams. And so then they're sleepy during the day and having some other adverse effects. The other thing to mention with melatonin is if you're giving it to like toddlers, younger kids, school age, it can make dreams more vivid. And so it can show up as kids saying they have nightmares.
Wow.
Sorry, that was longer. I don't know if I answered your question.
That's all right. No, that was great. Thank you.
Any
You
other questions?
validated with what I did, which was I don't want them to make my kids to make
Yeah.
assumptions. They need something to help them fall asleep, as opposed to sort of working through the behavioral aspects of
Yeah, of like, yeah. And then again, that's why I go back to the mindfulness stuff is with electronics and, this constant bombardment of information, there's less opportunity for kids to have that alone time, have that quiet time, be in the moment. And, there's always TV on, phone on. Sometimes both of those are on while they're doing homework or something else. It's the world we live in now.
Yeah. Great. Well, thank you so much. If there's no other questions, we can finish there. I will just let people know about our talk for next week. So we have Dr. Mina Khan, who is at the Ohio State University, and she's going to be talking about something I don't think we've actually ever had a talk on as part of the sleep seminar, which is phrenic nerve stimulation for treatment of central sleep apnea. So love to see all of you again next week, and thank you for joining us. And thank you again so much, Dr. Patwari, for a great talk this afternoon.
Thank you. And email me for any questions. Happy to respond.